I think most of the myeloma community is aware of both of these clinical trials. This is a combined data set that has slightly more mature data. I think that one of the primary issues has been about toxicity of carfilzomib, and both of these studies continue to show that patients on the carfilzomib arm of these studies come off of therapy less frequently on the carfilzomib arm because of toxicity-related issues than on the control arm. So I think that's very interesting, given that patients were on the carfilzomib-based therapies for about 50% longer than they were on the alternatives. So the fact that this data continues to be the case, I think, is one of the most important things, because I think that perhaps the biggest barrier to utilization of carfilzomib has been, I think, largely unfounded concerns about toxicity. So I think that is perhaps the most important observation. In terms of efficacy, it continues to show significantly superior efficacy for the carfilzomib-containing arms. So just to be clear, one of these trials is lenalidomide and dexamethasone versus carfilzomib. Lenalidomide and dexamethasone, that's the ASPIRE trial. And one is higher dose carfilzomib and dexamethasone versus bortezomib and dexamethasone. And in both of those clinical trials, the efficacy signal was enormous. The ASPIRE, the carfilzomib arm of the ASPIRE trial is probably the single best arm in any randomized clinical trial to date. The high-dose carfilzomib arm of the carfilzomib bortezomib, I think, to a great extent lays to rest the issue of which is the most efficacious proteasome inhibitor. Well, I think the biggest concern are cardiac or cardiopulmonary kinds of toxicities. So the sort of the number one kind of issue with carfilzomib is shortness of breath, and I think that is the concern. And while it certainly is a real toxicity, it shouldn't be a barrier to utilization of carfilzomib, at least in my opinion. The original presentations were from ASH, two ASHs ago, so it's that much more follow-up. And I think the combined data set and the toxicity issues are probably the most important aspect of this. To some extent have seen that already. There's significant data sets. Andrei Jakubowiak from University of Chicago certainly deserves much of the credit for examining the upfront utilization of carfilzomib in combination with lenalidomide and dexamethasone. And I think that in our efforts to cure myeloma, that this is going to be sort of the centerpiece of that. Whether we see additional drugs, I think clearly there's some excitement about carfilzomib, lenalidomide, dexamethasone plus daratumumab as an initial intervention for patients with multiple myeloma. Is that going to be the thing that sort of gets us over the hump, at least in a subset of patients with multiple myeloma, so that we can really see biological cures? I think that's something that the myeloma community is very excited about.